How do you do that? Okay. The patient must accept a screening program and must cooperate with you. And this has to be backed by efficient healthcare system and proper financing. Let's go. The first problem we're going to have in this country is that we cannot define properly our colorectal cancer disease burden, and this actually applies to other cancers. So we are dependent on hospital statistics. So we can only calculate the crude incidence for colorectal cancer in Nigeria, which does not do justice to the disease. But there are some serious issues about the disease burden we should be concerned about. One is the dramatic rise in the incidence. From the time Bucket told us that colorectal cancer was a rare disease and Africans are immune to colorectal cancer. I mean, to now, what we've seen is a bit of drama as far as the rise in incidence is concerned. And we are not stopping there. By 2030, we are expecting about 70% more rise in the incidence. Now, it's not only the dramatic rise in the incidence, it's about the mortality as well. For every patient you see here with colorectal cancer, the chances of death is 75%. Half of these deaths will take place in the first 1 year. You see data from this hospital. Colorectal is behind prostate in men, behind breast and cervix in the females. Just to tell you what kind of problems we have with this disease. You have to remove it. Which risk factors are fueling this dramatic increase? Of course, our population is aging a bit more, but that's probably not where the problem is. The problem is with the fact that we have taken off lifestyles that are foreign to our people. We took up, after the colonial masters left, we didn't take their good habits, we took the bad ones. And the bad ones are now causing us problems. In particular, WHO told us a few years ago that consumption of processed meat and red meat may be carcinogenic, particularly to the colon. Now, we know how big the meat consumption industry is in Nigeria. Snacks, meat is eaten as snacks, as staple food. It's also taken as delicacy. And go to every street in this country, any corner of the country, it doesn't have to be Sokoto or Meduguri, go to Calabar, processed meat is sold. We do not know what chemicals are used in processing. We don't know the carcinogenic effect of overheating the meat and producing hydrocarbons. How much hydrocarbons are produced from processing, we do not know. Colorectal cancer arises as a result of mutations, and there are different pathways involved. Most of the cancers are sporadic. About 5-6% are hereditary, and the pattern of inheritance is by autosomal dominant. About 10% to 30% may be familial. Now, let's look at the picture of this disease as we see in this environment. There are two important characteristics I want us to focus on. One is the fact that the average age of our patients is about 15 to 20 years lower than the average age worldwide. And then the fact that 40% of our patients in this environment develop the disease below 50. You know that worldwide, 90% of the disease is after 50 years of age. But that's not the only problem. The other feature I want you to look at is the fact that 9 out of 10 times we see colorectal cancer in this environment, the disease has already spread beyond the colon. What does this mean in terms of staging? We see that 2/3 of the patients are presenting with metastasis. We see that if you have metastasis, the chances of survival is very abysmal. Why do our patients present with advanced disease? We know some of the reasons. No population screening. The other thing is that we have more aggressive tumors, and then we also have poor referral system for our patients, and there are certain socio-cultural factors which you have already been told. Among them is the cultural perception of the disease, the fact that our patients have to go through a third party. Once you have symptoms in this country, you will usually go to a third party before you end up at the hospital. And of course, we have heard about out-of-pocket financing of healthcare in addition to other factors. This is the story. You have transition from normal colonic epithelium to cancer. In the pathway of this transition is what we call the adenomatous polyp. Now, if you get that polyp out of the patient by colonoscopy will help you to detect the polyp, and then it will also help you to remove the polyp. The patient does not develop C, which is cancer. And in the event that you are seeing the patient with cancer for the first time, the screening will help you to prevent progression, because colorectal cancer has a slow growing early phase and only becomes symptomatic when it is advanced. So the best time to get rid of the disease, it is at that asymptomatic phase when symptoms have not appeared, and that's what the screening does for you. Your screening population can be divided into two. The average risk, the standard average risk is 50 to 75 years, but now the latest guideline says that 45 years. This 45 years to accommodate the problem that is seen in African Americans who develop the disease earlier than the whites. In our own environment, we may start thinking of average risk below 40 at the age of 40, rather than any of these ages that I mentioned. And for the high risk group, colonoscopy is the screening option. But when you are looking at the average risk patients, what you have is a menu of options which include colonoscopy. Ideally, you would prefer that the patient goes for colonoscopy, but that comes with a little price, because that patient has to go through an inconvenient bowel preparation and procedure. Nobody here would like to recommend bowel preparation easily to his neighbor. I can tell you, if you've ever gone through it or seen somebody that has gone through it, it's not an easy experience. And that is why there are options. Now, the commonest options are stool-based tests. And the simplest of the stool-based tests is the fecal occult blood test. It is the easiest, cheapest, and is administered by the patient himself. Now, the problem is that there is poor sensitivity. In fact, the best sensitivity you can have is with about 40 to 60%. And that means that to make it more accurate, the patient has to do it several times and too frequently, which brings the problem of compliance with the fecal occult blood test. And therefore, and in some cases, like us in Nigeria, our people don't like to mess with their feces. They don't like to mess with their poo. So that is an anticipated problem with that test. Now, the prototype of the direct visualization test is the colonoscopy. Now, that solves your problem because it picks the cancer. While the stool-based test only pick the cancer, the colonoscopy will pick both polyp and cancer, because polyps don't bleed that much. They don't shed too much material in the stool in form of blood or in form of globin or in form of DNA. But with your colonoscopy, you see everything. Now, there is the blood test which is under investigation. That is the septin-9 assay. It's a blood test for, it's a blood-based molecular test. For the average risk group, colonoscopy reduces cancer death by over 30%. This is one of the take-home messages for us today, especially for those of us who are over 40 years of age. We must remember this, that if you offer yourself to colonoscopy, you are likely to reduce the likelihood of developing colorectal cancer by at least over 30%. These are the recommendations for the high-risk group. The difference here is that you start screening at a much earlier age, and the frequency of colonoscopy is more than the average risk. Now, how feasible is this in Nigeria? First problem is that we can't justify putting money into screening because we do not have proper data. The second thing is about the fact that can we trust our National Health Service in terms of coverage and in terms of efficiency. And then we know what our health budget does for us at the moment is thrown at communicable diseases. Simply because corruption won't allow the things that are supposed to prevent communicable diseases. That include what? Water supply, sanitation, hygiene, housing conditions, basic living conditions. the guys who steal our money take up this money, and therefore we can't afford. It will be difficult for us to fund population screening. But if we decide to screen, there are certain technical problems we have to think about. One is the age. At what age do we start? Okay. Now, screening in Nigeria is opportunistic. That is what we are doing at the moment. Okay, and we must maximize it. Before you have to take a number of factors into consideration if you are going to maximize opportunistic screening. Next time. We are not immune to any form of colorectal cancer in this society. All the forms have been found here. Let's go. This is familial adenomatoous polyposis. Let's go. Let's go. Keep going. Sorry, we can't see that clearly. Let's go. Let's look at our own hospital. We have some erratic problems even with the data collection. So the patients are going to oncology, some will go to surgery department, some are going to pathology lab. We don't keep enough records of these patients. And again, can we run a counseling service? Have we tried community awareness campaigns? Do we have screening for our staff? Of course, these are issues that we need to look at. Yes, let's go. At national level, before we have to look at the possibility of federal legislation. If you have ever listened to the cancer control policy of this country, you will feel sorry because it's an apology, and I once did that and I was not comfortable. Let's go. Let me just summarize some of the things I've said. Here is my Oga, and I want to set up a colorectal cancer screening service for the hospital staff. The target population is the hospital staff. Okay? And he has justified the fact that the incidence requires screening and is willing to commit budget to it. The first thing is what we are doing now, awareness campaign. And then there must be reminders through posters, electronic media, social media, all the time about the problem. And then he's got to go to the unions. Joesu would like to know what is happening. And he will have to set up a screening policy. This includes the age to be screened, the tests that will be done, and the frequency of screening. And then he has to appoint a screening team. This will include administrators, hospital record staff, statisticians, in addition to GIT staff, GIT doctors, both surgeons and physicians, the laboratory staff that are going to be involved. And then he has to set up the screening services, which will include setting up endoscopy hubs. These hubs will be determined by the population size of the hospital. And again, the hubs are supposed to be very well equipped, the staff properly trained, the endoscopists trained to be very efficient at picking out the problems. And then again, the hospital has to provide fecal occult blood kits and laboratory support. Then we execute the screening, and after execution of the screening, we have to audit to make sure that no harm comes to anybody as a result of the program. Let us look at the execution. Let us say we have an average patient. The average patient is one that has no other risk factors other than age. He has two options. Take fecal occult blood test. If it's negative, it's done twice every year. Okay? But he has the option to do a colonoscopy. Okay? But if the fecal occult blood test is positive, he also has to go for colonoscopy. Now, the same thing, the high-risk patients will go through colonoscopy. If polyps is found, a polypectomy is done, and the patient becomes a high-risk group, so that the further screening has to be done frequently. If cancer is found, the cancer is treated, the patient is pushed back into the high-risk group, for which colonoscopy may be 1 to 5 years. And if the colonoscopy was initially done for an average risk and it was negative, nothing was found, what it means is that the patient should come for colonoscopy, will be coming for colonoscopy every 10 years. Yeah? Thank you very much.